heard that Google has sometime, like we are following, so we know you might have heard also. So they have prepared this device so that by capturing um, uh, this eye, right? So they can they can keep track of this hypertension and diabetes. So retinal examination is a non-invasive way to assess overall health, and so it is going to prevent us, because vision loss is irreversible. And so if we can do some timely intervention, then we can, we will not go into that situation. So when we talk about images, which images are there? So fundus images and OCT images are mainly used for the ocular disease analysis. And among these, OCTs are, fundus images are more common, and most of the clinics, fundus cameras are available. But if you go for OCT, these are the costly device, and a big machine is there. So this is now this is also coming into the picture. So we are going to analyze fundus images and OCT images. Although we did some work on OCT images also, but today I will cover the work on the fundus images only. So when we see, this is the anatomical structures which are present in the fundus image. So here, what is a fundus? Basically, fundus image is a 2D projection of 3D retinal semi-transparent tissues, which are obtained using the reflected light. And you can see all these structures over there. So here you can see the fine, see there are fine vessels. Sorry, just a minute. Yeah, these are fine vessels. So you can see these blood vessels are there. Then this is called optic disc. Then some major vessels. This is your fovea, macula. So these are all the basically structures. And what we need to do is that we need to keep track of their structure, right? So if there will be any if these structures will be affected by disease, then they will show some abnormality will be shown over there, right? And that is what we need to pick up. So if you talk about diabetic retinopathy, glaucoma, any those diseases, so where we are going to examine these structures only, right? So how these structures, the changes are appearing in this structure, and we can find out the diseases. So when we talk about fundus image analysis, we know that actually here you can see that this is a fundus image where many sort of abnormalities are there, right? So how we are going to identify these abnormalities? So if we are looking for glaucoma, then we up to disc ratio, right? And if we are talking about diabetic retinopathy, then we are looking for these veins. Like here you can see this is a exudates, this is the hemorrhage. So the blood leakage is there over. So basically this is what we need to see. Then when we are talking about cardiovascular diseases like hypertension, then in means, so their ratio is going to be disturbed. When we talk about cataract, then again we will see that this optic disc, foveas, and the other parts of eye becomes hazy. So that is how the presence of cataract is identified. When we talk about age-related macular degeneration, here what happens that we are going to either there will be dead retinal cells will be there, growth of fresh blood vessels. And any vessels, if they are being growth, that is also bad. Like it is not like that we are getting fresh blood vessels and that is good. So that is also bad. So, and when we are talking about myopia, then it is causing critical vision diseases because of the this epithelial layer, right? So that diminishes, and that is how this myopia happens. So you can see that these by analyzing fundus image, we can get a lot many information depending upon what we are looking for. So this picture is summarizing fundus image of eyes with different kinds of anomalies. So you can see that this is your normal fundus image, glaucoma, diabetic retinopathy, AMD, cataract, hypertension, right? So all those several times, more than one disease is also present over there. So these are some examples shown to you. Now when we talk about go for diabetic retinopathy, then you can see that this is basically here the blood vessels, blood vessels are being affected. They are doing dysfunction, and so that is actually caused by sugar, right? So we can say that's diabetes. So, and you can see here in this picture, right, it is too much, like in even in developed countries, this is a more uh, prevalent problem. So, diabetic retinopathy is actually a complication of diabetes, maybe type 1 or type 2. So, we know that in type 1 diabetes, the body does not produce insulin, but in type 2 diabetes, insulin, or the cells ignore the insulin, right? So, this is how. So, but what is the problem? That initial stage, it is asymptotic, right? So, we do not get any symptoms. And what happens when this low vision happens, then only we came to know, yeah, something is going on. So that is what is a problem, and that is why uh, uh, finding out a disease at its onset, that is most important, right? So in the early stage, as I told you, you will not get symptoms, but as the disease will progress, then there are symptoms. For example, blood vision will be there, floaters, fluctuating vision, distorted vision, dark areas in the vision, poor night vision. And so what happens here when you talk about floaters? So many times we have like I was like a couple of years back, I got these floaters. When I got checked, then they said, okay, this sometime what is happening, that is a natural phenomena, there was no problem, it was well, then again it I mean, I can see a floater now. So sometime what happens that uh, we don't care about it. We say that okay, this will be taken care, or sometime their presence is what in our body, things are वो कहते हैं ना, I mean, they are being meek and they are gone. So that type of thing is also there. That is why we do not, many times we do not able to focus, but you can see that several symptoms are there. So DR, as I told you, is caused by interruption of the blood supply by veins either, or and leakage of lipids and fluids from the blood vessels. So here you can see that these are the four things over there. So you can see this microaneurysms are there, then soft exudates, hard exudates, and this hemorrhage. So where the leakage of lipids, here you can see that these are being deposited in the eye, and that is how that is creating problems. So what are microaneurysms? You can see the most difficult thing here, right? You can see here you are not able to see that, okay, here you can see these changes, right? Here also changes are visible, here also changes are visible, here also changes are visible. But the most difficult case is microaneurysm, right? Because these are the early signs, right? So earliest clinically visible changes of diabetic retinopathy. And so when we talk about AI methods, then for even for our developed method, so the finding out this thing is difficult, not only for AI methods but also for the experts, right? It is difficult for them also, so they are looking for. And so when we discuss, then they, okay, if you can, because when the disease is visible, right? In case of, you can see hemorrhage and exudate, so no problem, right? But we want to at the onset of this, right? That is so. What are soft and hard exudates? These blood retinal barrier is and the lipids are deposited in the retina, and in the hemorrhage, that is in the hemorrhage, bleeding occurs in the retina, right? So these are the things we need to focus when we want to look for diabetic retinopathy. So here you can see this is another picture where you can see microaneurysms, exudates, hemorrhage. So when we say the clinical studies, then the severity is categorized into 5 stages. So when we need to do the classification, basically 5 classes are there. So normal, then mild, moderate, non-proliferative, and proliferative DR. Sometime in some of the data set, mild and moderate, this grading of the DR, when ophthalmologist does it, obviously it is a time consuming process, because he requires to examine uh, several lesion parts of the human eye, and there this AI may help us. So here, this is the picture when I was okay. So you can see the first one with no DR, and the second one with mild DR, third one is moderate DR, and then the severe DR and proliferative DR. So here you can see that no abnormalities, and in the mild, as I told you, that is the one which is the most challenging. So we are having microaneurysms only, and but then the things start, right? So you can see here the and the lipids will come out, or the blood will come out. All these things are there. Okay. So now come to the role of AI or deep learning in the disease detection. So here you can see one example is shown where CNN architecture can be used for the disease classification. So deep learning models, especially convolutional neural networks, can analyze retinal images so that to detect these diseases we just talked about, DR, glaucoma, and all those. And here another good point is that these deep neural networks, they can automatically learn these features, and we can not only see one thing. After classification, we go to the next level of the problem, that is segmentation. So we do not only want to know that okay, the problem is there, but we also want to know that where this problem lies, these deep neural networks, they can learn and extract these critical features from the retinal images, which improves the disease localization and severity grading. So we want to grade them. So we have models here, but before I tell you about one of the model which was developed in our lab, there are several challenges in ophthalmic disease detection. First of all, this challenges the not only ophthalmic. In fact, I am going to show you the challenges which are in general true for whenever you go for the medical image analysis. So first of all, there is a quality issue because lighting, camera resolution, artifacts, they are going to affect the picture quality, picture clarity. Then there is a scarcity of labeled medical data. So as I told you that data sets are there, but these data sets cannot be used unless and until you have ground truth for that data set. And so that is what I was telling you, that we collected a data set from Jabalpur Medical College. So like we used to be, my student Nidhi Gupta, she is at NIT Kurukshetra now. So she worked on this problem. So she used to go there, sit for the full day, and I mean, of course, because they were very busy, so they find out times from their busy schedule, and then they helped us, did that ground truth labeling and all those things. And here, when we call this labeling data, especially in case of fundus images, or then the data differs across different ethnicities also, like Asians, Africans, then let us say white people. So somewhat it is somewhat difference comes into the data set. So that is how, when we go for the AI model, if there will be variability in the data set, then the AI model, which is developed for one ethnicity, that may not work for other ethnicity, right? So we need good amount of data so that we can train our model, we can make our model generalizable, right? Then need for expert ophthalmologist and high workload. So of course this manual diagnosis requires a lot much time, and so the thing is that they are already busy. If you ask them to do this job for you, then I mean, it is very difficult task. So let me tell you another experience, like our last work in this on this ophthalmic disease. One of my student, Dr. Neha God, she worked on it. Right now she's a postdoc at Abu Dhabi, this Dubai. And then another student, he's about to submit his thesis, Amit Bhati. So the last work of his is based on the uh, GAN, right? So generative AI. So we have developed a model where we are developing, it is generating images, because I will show you that many times in the data set there are very less amount of images, so they cannot be used to properly train our model. So these days generative AI is there, where data can be generated. So when we generated data, then of course nobody, like when we will submit paper, it is the paper is submitted. So the I mean, how the reviewers will believe what is going on? Because when we go with the generative this let us say we are talking about generating artificial synthetic images, then we want images to be from the same domain, similar but not exactly similar. We want diversity also there, so we need to prove it. So although there were some parameters based on which we showed in our paper, but then the stamping from the ophthalmologist is was very very important. So we shared analysis, like we shared a data set of 50 images, right, where we mixed it, the actual images, then the images generated by our model of different categories, and we gave it to the three ophthalmologists, and we asked them to tell us, like which is this if they feel that this is not a real image, or like we got their viewpoint. So although our work stands well over there, but remember, it was very difficult to get their time, because if you ask them to label 50, 100, 200 images for you, then difficult task, right? Then we have subjectivity in the diagnosis, because there might be variability in the human grading. So let me tell you, especially in the case of microaneurysms thing, when we showed it, there was some difference among the three ophthalmologists also, right? So there might be variability in the human grading, which may introduce inconsistency in the labeling process. And if we are using that to train our model, then of course it is going to affect our model performance. Then there are computational constraints, because the deep learning model, they are the resource intensive models, and it is very much challenging to deploy these models on the edge devices with the limited hardware. For example, what we want that the nowadays everything we want to be get done with our mobile. So I was giving you example of precision agriculture. Now here also, in one of the application, like we are working for another modality, that is on for dentist, actually, the teeth. So with the device, so what we want again there, that the device captures data, and our model is there, that so that model analyzes it. And so there is a mobile app, and quickly on the mobile app, it gives you the findings, and so it shares data with the expert also from there itself. And so you can get experts opinion as well as our model opinion. So I mean, so if you want to do all these things with the edge device, then your model must be a lightweight model. So that is again a problem. Then this model biasness and the generalization issue. So as I told you, that the model which is trained on a single ethnicity data set, that will not perform well against the diverse population. So if you want that, because it has been observed that there is difference in the pigmentation in the eye, so belonging to different this ethnicity. And finally, there it comes interpretability and trust in AI. So AI that is considered as a black box. So this is raising concern about the explainability. And nowadays, not only for medical, basically, a lot of work is going on. So this is another research area, that lot of work is going on. How to make our model explainable. So explainable AI is another area of research. So you can see that these are these are the general challenges, you can say. Now these are the fundus image data set. So you can see that so here I have written this S and C. So C for classification, S is for segmentation, and this L is for this localization, right? So you can see this earlier only this data set was available, right? So see how small data sets are, right? So and now we are getting larger data sets. So here you can, the challenges with all these data sets are given. Somewhere we are having low resolution, somewhere we are having poor quality, somewhere imbalanced data set is there, somewhere images are suffering from noise and lens correction. So every data set is having its type of unique challenges, right? So now let me come to present you one of our work, that is an interpretable dual attention network for diabetic retinopathy grading, IdeaNet. And this work has already been published, and here the focus of this work is to provide an improved DR grading, and not only grading but the severity specific lesion segmentation. So we are doing not only the grading but also the classic this segmentation. And so these as I told you that most of the methods which are existing, they were trained and tested on the seen data only. But when we go for the real time applications, then obviously the sample would have may have the different illumination condition, different optical factors, and so there might be the sample characteristics might be different from the training samples, right? So we want a model that can identify a correlation among the lesion region specific pixels in the entire pixel space and able to detect the small size lesion parts effectively, right? So that which is required for your diabetic DR, efficient DR grading, right? So if you look at, this is the architecture of IdeaNet. Here you can see that it is shown with different boxes. So this is your backbone network, and here we are having this dual attention block. Finally you can see this grading, and then through line we did the interpretability also, right? So here the novelty of this IdeaNet lies in the implementation of this attention block, right? So here we are having dual attention, which is a parallel attention. You can see that BSA and CPA parallel, they are being applied. And so here and so as compared to the recent works where only serial attention was being used, so why we use this parallel attention? Because the motivation was to capture the small lesions in the fundus image more efficiently, right? That was our aim. So this attention technique, right, it uses this singular self attention, but it uses a combination of multiplicative and additive scoring mechanism to highlight the important features without losing the information with the small gradient, right? So for better learning, so we are using this bidirectionally spatial attention module, BSA, and a channel wise parallel attention module, that is CPA. So see here this BCA and BSA and CPA, right? See here. So these modules work in parallel to capture the lesion-specific features from the input fundus images. And here this IdeaNet comprises a backbone network. Okay, so that is what you can see, backbone network followed by dual attention block. So the feature maps which are obtained from the backbone, this is FPN, right? So these maps are being fed to both the attention blocks for further refinement. Here BSA block is a self-attention based block which captures the relationship among pixels for the whole image. And the good point here is that I will show you through experimental study also that these two blocks act in a complementary way to detect the heterogeneous regions. So BSA block focuses on the relatively large size regions, whereas CPA block, it focuses on the small size regions. So BSA block redistributes spatial pixel weights by aggregating row and column wise pooled feature information to extract the contextual information. While your CPA block uses parallel branches of, I will show you the details of these blocks, where CPA blocks uses parallel branches of the global max and global average pooling to excite this channel contextual information, and it pays attention to important channel information, right? So the feature maps which are obtained from here, from both the blocks, they are concatenated and then convolved to get the refined feature map. This FC is the refined feature maps. And so this then we apply global average pooling on this FC, which is followed by fully connected layer, and there we are going to get this diabetic DR grading classes, right? So working together, these BSA and CPA blocks are identifying, as I told you, a diverse region. BSA focuses on the larger size region, CPA focuses on the smaller ones, right? So that is how they are complementing each other. And so a good point is there. I will show you that this model is tested on a completely unseen data set also, of that is also belonging to the different ethnicity. So and we found it to be good, giving good performance. But let us first focus on the BCA and CPA block. So here there is one mistake. This Just a minute. This okay. Here this will be not average, but this will be max. Okay, so your first let us focus on BSA block, right? This is a bidirectional spatial attention block, and so this as you can see its name spatial attention. So it is, this block is generating spatial attention weights to focus on the informative part of your fundus image. And so what this self attention mechanism does, it takes n number of inputs and performs an interaction operation among them, so that it can identify which pixel position should be paid more attention. And as compared to the standard convolution operation, we used here self attention operation, which increases the receptive field size and less computational cost, right here. And the feature maps which are captured by the backbone network, they are passed to BSA module, and max pooling is applied in both directions along the channel axis. So this row wise feature and the column wise features, here you can see this FH and FW. Sorry, this FH and FW, they are you got this, and this row wise pooling captures relationship among pixels for each row. Column wise pooling captures a relationship among pixels for each column of the input image. And finally, these obtained row and column wise vectors, they are multiplied together. Here you can see they are multiplied together to get the feature map of size H cross W. And this is followed by, you can see, convolutional layer. And finally, this softmax activation is applied to get the spatial attention maps, this FHW here. And now we want to put the excitation here. So to excite the features obtained from the backbone network, element wise, here you can see this element wise multiplication of FHW and the input feature maps, this FBN, that is performed for all channels, and this is followed by element wise addition operation. And so that is how finally we will get the bidirectional feature maps, this, right, with enhanced spatial features. So the model this way is selecting the robust semantic representation of the image. And then we come to the this CPA block, right? In the CPA, see the channel attention, sorry, although each channel contains this information, important information, but there might be some redundant data. So this redundant information actually contributes to if you are going to carry on this redundant information, then there will be unnecessary computation and unnecessary storage. So we want to save on the computation side. So we want to remove this redundant information, or we want to suppress this redundant information which is present in the feature maps of the backbone network. And so here this CPA block, it redistributes the channel information by paying more attention to channel features having disease specific information. And here we are using this global max pooling and this global average pooling also. So the CPA takes feature map from the backbone network and performs point-wise convolution with K filters, right? Here you can see KC. So with K filters to generate feature maps, where K is how many we need to choose. Basically, K is the number of grading classes. And this FA and FM, they contains this class wise scores for each of these classes, so that the importance of the class wise features may be captured, right? So this spatial information which we obtain is actually squeezed by, you can see, global average pooling and global max pooling in parallel. And at next, these features are further downsampled, and the two vectors, they fed to the parallel multi-layer perceptron with two layers. Here the first layer uses this C by 64 units, and the second layer uses C units here, right? And this MLP generates the excitation weight, and each of these weight vectors are then channel-wise multiplied with the input feature maps, followed by an element-wise addition operation. So we are getting the refined channel-wise feature maps, which are produced by applying the sigmoid activation function, as you can see here. So the parallel output here, the output of BSA block and the output of CPA blocks, they are concatenated as I showed you earlier. And then we apply the fully connected layer for DR grading and classification. Now, if we look at the performance, then this is the performance of the idea net on the, so here dense net one, when we perform, so I mean in the paper, the details are there. So when we did this study, then we found that DensNet 121 works well as a backbone. And these are the, you can see the AUC ROC plots for 4 data sets. So here you can see that this if you look at these graphs, then you will see that so the first one is for Mesador, this one is for Mesador, this one is for IPEX, this is for IDRID, and this is for DDR. Now I think you can see that where we are getting the best performance, where we are getting the worst performance, you can say. So the best performance we are getting in case of Mesador. So we want that this AUC curve, right? So India area under the curve should be as max as possible. So we want our curve to be on this side. So you can see that the performance is best here in case of Mesador, but it is least here in case of DDR, right? So why so? Why? And I mean, here they are good. So why so? Because the Mesador data set, this is having high quality fundus images, and we are getting good performance here with the IPEX and IDRID, because IPEX is having higher number of images for each class. But here you can see why we are not getting that much performance with the IDRID, because it is a smaller data set as compared to Mesador and IPEX. Then why we are getting this poor performance with DDR? Because in the DDR we have poor quality images, and many times the images are blurred also. So now this is the grading performance. Just have a attention here. So here these are the heat maps which we propose for IPEX data set. So here you can see the original fundus image in the first column, the original fundus image, and we made a boxes here. So you can see that sometime you are not able to, I mean, very quickly you are not able to understand what is there in this box, right? So these boxes are actually are not used to show that here are the abnormalities which we want to predict. So here you can see that normal, mild DR, moderate DR, severe DR, proliferative DR. So you can see again our problem is what? You can see the mild DR, you can see, right? I mean, it is very difficult to identify. Okay. Now, these are the heat maps got from backbone. This is the output of BCA block. This is the output of CPA block. And this is the output of our final layer. So you can see that if you look at these third and the fourth column, right? Look at the third and the fourth column, you can observe that BSA can identify heterogeneous structural lesion parts efficiently, while your CPA block is effective in detecting small sized retina. See here, these here BSA block is not able to capture what CPA block has captured, right? So we can see that. So, and similarly, the cases where CPA block fails, then the BCA block does it. So these CPA and BSA block, they are complementing each other in the lesion detection. And here another interesting thing is that there are cases when your backbone network fails to identify high level features, but the model captures. See here, right? But your model captures it. So that is the good thing with this model. And so we can see that especially if you see the focus on this mild DR, because that is the most challenging class. then the features captured by the backbone network, they are actually being refined by the proposed attention blocks so that they can discriminate the DR severity specific information. And here you can see this is the ablation study, you can say only backbone. This is the performance, backbone plus BCA. You can see the performance is improved, backbone plus CPA. Again, the performance is improved, and this is how this is our final where we are using both these blocks. So you can see that the performance is uh, improved, right, with these blocks. So now this is for the now we come to the this okay, now here these are the results where the comparison is being made. So you can see the comparison on the um, this Mesador, IPEX, and this DDR, as well as iterate. So this is the comparison. So you can see we are using different parameters, and we had to do it because in these papers, I mean, they have shown performance on these parameters only. So we wanted to compare them on the same level. Because I said that cross data set evaluation is one of the important part, because we want to see whether our model is generalizable or not. So here you can see that we are training, this model is trained on IPEX data set, but tested on IDRID data set, right? You can see it's still good performance. Okay. Now the training is performed on DDR data set and testing on IDRID. IDRID data set is an Indian origin data set. So what I'm trying to say that we are also checking that, because that was also a challenge, that model trained on one ethnicity not working well for other. So here you can see the I mean this IdeaNet is performing quite better. So why the performance is low here? Because we are training our model on DDR. DDR is not having a good set of images, and that is how the performance is not that good, right? And here these are the these are the segmentation results. So this is your cross data set study, and these are the segmentation results which are scored on the this MIOU and DICE score. So here also you can see this IdeaNet is performance. Now just see it in the form of a picture. So this we have used this lime method so that you can see the performance here. So you can see the here because so we have taken that microaneurysm case separately because that is the most difficult. So, but here these soft exudates, hard exudates, and hemorrhage cases are being taken. So original images and ground truth. Now you can see these are the two here also you must have seen this cabinet and let that they are the state of the art when this method was published. So so we have compared our performance with the state-of-the-art methods, and see these picture is self-explanatory, right? So these are the ground truths. This is the lesion part detected by cabinet, lesion part detected by LAT, and this is our method. So you can see here like how this is working. Okay, so see, but sometime it is not like that. Like our this model also sometime doing I mean this is false positive, right? Because see this is not being shown here. Okay, so now if we consider it on the this okay, so we just saw that the IdeaNet can identify low contrast as well as blurred lesion parts effectively, and your IdeaNet can differentiate the background and the lesion parts more accurately as compared to state-of-the-art method. And now our focus is on the small lesion. So you can see the here the green, red, and blue, oh, sorry, green, red, and yellow boxes are there. So green boxes are denoting your ground truth of microaneurysm lesions as well as lesions which are correctly detected by the model. So those things which are detected by model, they are shown in the green box, and the cases when your model failed to detect the lesions, they are highlighted with the yellow box. And the false detection, right, it is not there, but the detection is shown, that is shown by the red colored box. So we can see that if you just see this, compare the three methods, see the ground truth, cabinet, lat, and proposed. So the you can see this IdeaNet can identify. Here you can see right? So just see here, right? So you can see your eye is can identify most of the small sized lesions, microaneurysm lesions, and which is not the case with the state of the art methods, right? So sometimes the misclassification is also there. Okay, so while these cabinet and lad they fail to capture small size lesion parts, IdeaNet is able to capture those. But IdeaNet also there is some limitations. What are these limitations? Only in few cases their lesion parts are very small, just a few pixel, 1 2 pixel, right? If it is there, so here actually if you look at this here, you are not I mean it is difficult to identify. Here it is there, right? If you can focus. So here when they are just a couple of just 1 2 pixel to 1 to 2 3 pixels, then the IdeaNet is also not able to detect it, right? So because as I told you, microaneurysm and soft exudate, so hard and then the hemorrhage, they are easily identifiable. So microaneurysm and soft exudate lesions, they are the primary contributors of the mild DR, and are a little bit less detection rate for mild DR on IDRADE and DDR dataset is observed as compared to other classes. So these are the results which we obtain with IdeaNet. So if we take a bird eye view on the IdeaNet, then it is giving you the good point is what, that it is giving you superior performance for lesion detection on unseen data. But remember I told you that if the lesions are very small in size, just a few pixel, or they have color which is very similar to background, then IdeaNet also fails to detect them. Yeah, I mean, this is the same point, but remember what is the problem? If you say that not only for IdeaNet, if you talk about 1 to 2 2 to 3 pixel size lesion, it is difficult for humans also to identify. So and also if your lesions are getting blurred due to optical errors in capturing fundus images, obviously, this IdeaNet is not able to capture. And so and as I was telling you, so we have not checked it, right? We have checked it, like for example, some generalizability we have checked by training it on some other data set, testing it on a data set of different ethnicity. But while doing this study, we observed that the fundus images are comparatively light pigmented in case of Caucasian patients as compared to African or Asian patient. And unfortunately, we didn't have data, so we can't say. But I mean, I don't know, like about this idea, and it may suffer from this data set bias. Now, the performance may vary for the minority classes. Obviously, if you are going to train any, like this is not with the IdeaNet, it is in general true for all AI models, that if you are training it on the imbalanced data set, obviously the model will become biased towards some, right? So just to conclude, we are on time. So just to conclude that diabetic retinopathy is a serious complication of diabetes, which can be detected through fundus image. And here we know a lot of methods. If you just see the literature, this AI and deep learning, they have revolutionized the fundus image analysis, and lot many methods are there where day by day we are getting improved diagnostic accuracy. So here, but still, as I told you, there are several challenges, and those challenges are yet to be addressed: image quality, data set limitation, explainability. So that is still there. So at the end, I would like to say that AI assisted diagnosis, it can enhance the clinical decision making, and it can improve the accessibility to the eye care. Of course, like for example, like as I told you that I'm also having like for past 1 year this floater. So but sometime like schedule is so difficult that it is really difficult to go to the doctor because they dilate and it takes full day basically. So if we are having, because nowadays lot much efforts are going on so that we can have with the help of mobile, if we can develop some sort of imaging technique, and I mean some sort of fundus image, it can be captured, right? So it can be captured, and so that some initial thing we can have, or I can send up because they know me. So I mean, I mean, you can also. So once these images may be sent to the doctors and they can advise you, all those things are possible. So we can say that continued research and the technological advancement will definitely improve early detection and treatment. That is what we are looking for. So this is all from my side. These are the references. Uh, okay. So thank you so much for your patient hearing. So we are on time. Yeah. Thank you.
If anyone having any queries, please ask. Thank you, ma'am, for your inspiring words and insightful thoughts have truly enlightened us for our future. Now I call upon Dr. A. Jayaprabha, Professor in Department of Biomedical Engineering, to deliver a vote of thanks.
Good morning to all. It's my privilege to proposing vote of thanks in this wonderful seminar. First and foremost, I would like to thank our chief guest, Dr. Preeti Khanna ma'am, Professor, PDPM, IIIT DM, for accepting our invitation to deliver the talk on AA application in diagnosis and treatment for this seminar. Thank you, ma'am. A special thanks to our management and director, Madam Dr. Meenakshi Annamalai, for your motivation to conduct this wonderful seminar. Thank you, ma'am. I would like to express my thanks to our principal, sir, Dr. Kasinatha Pandian, for your support to organize this seminar. Thank you, sir. My special thanks to our associate dean, Dr. Sivakumar, sir, for your guidance and support. Thank you, sir. I would also like to thank our HOD ma'am, Mrs. Abhirami, for your engagement and contributions have made this seminar truly very memorable, ma'am. Thank you, ma'am. A special thank you to our faculty coordinator and student coordinators who worked behind the seminar to ensure the smooth execution on this event. I, I would like to thank all of our participants for your active involvement and enthusiasm in this event. Once again, thank you all for your making this seminar a grand success. Thank you, ma'am. Thank you
Thank
for
you.
a
Thank you so
wonderful
much.
Yes, ma'am. Thank you, ma'am. Thank you for a wonderful seminar. It was very truly insightful and it's engaging, ma'am. It is also very
Thank
useful for our biomedical students, ma'am. Thank you, ma'am. Thank you so much, ma'am.
Thank you. I'm happy that it is of some use. Thank you.
Thank you,
May
ma'am.
I
Thank
leave?
you. Ah, yes, ma'am. We can close
Yeah.
this.
Thank you.
Thank
Thank
you.
you so much.
Thank you so much, ma'am. Thank you. Thank you, participants. We will send you the certificate through the courier. Thank you so much. Thank you for your active involvement in this wonderful seminar. Thank you. Thank you all. We can, I think we can wind up the session. Thank you. Thank you all.
Seminar